Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, welcome back, everyone, to another episode. Today I'm with Dr. Jake Stucki. He's an oral and maxillofacial surgeon practicing in the Denver area. Jake, thank you for joining us on the podcast.
Yes, I'm super excited to be back. It's been a while.
Yes, I appreciate all the great episodes that you did with us, especially those trying to help residents and just navigating the whole process of residency. Those were fantastic.
Yeah, hopefully now that I'm out and practicing, we can find some time to do some more like that.
Absolutely. All right. So we have a great topic today. I'm excited about it. You know, on the podcast, we talk a lot about communication, the ways we talk. But I thought it would be good to do a specific podcast focusing on basically the language we use with our patients and also with our team, with ourselves, kind of just the language in general and how powerful it is. You know, we as surgeons, we probably underestimate the power or true power of language to either heal or hurt someone, because I think we focus more on our scalpel, healing, our tools, the way we use tools and surgical things. But, we can start out with the question of, does the words we use have any impact at all on a patient's ability to heal from surgery? Interesting thought. Any thoughts you have to start that question off before we get into the nitty-gritty of this topic?
Yeah, I really liked how when you brought this topic up and we had a conversation about it, and it really made me think about what the words we use, what impact they have on our patients. I subscribe to this email. His name's Dr. Greg, the helpful dentist. If you look him up, he's a general dentist who writes out tips every single day, and so many of his like pearls and his lessons that I've received over the last 5-10 years are about communication. What we say in front of the patient, what we say during procedures, and what the patients hear and experience from the moment they walk in the door to when they leave, and how it can make a night and day difference as to whether they will recommend people to see you, whether they feel like they had a good experience, and then now, a little bit what we're going to talk about is potentially even how their healing goes.
Yes, exactly. All right. So the goal of the podcast, hopefully, is to kind of equip surgeons and dentists, anyone doing dental surgery with the tools to kind of use language in a positive way to help their patient and their team just find a success. So let's start maybe with kind of pre-operative communication, pre-operative language. So a couple questions. One, I think that we all ask ourselves, and we probably ask this of attendings and residency, but a question is, how much should we tell our patients about complications prior to the surgery? What are your thoughts on that one?
Yeah, I mean, I feel like everyone's got a different approach to this. Some people are super detailed and they want to make sure they say every single thing to every single patient just in case. And, that's just kind of how their personality is. I tend to be a little more on the detailed side. And some people are just very minimalistic. If the patient doesn't seem super, worried about it or inquisitive, they just leave it at bare bones. My thoughts are, I like to sit down just for a minute, help the patient feel like I'm not rushed. I'm not running in there and be like, okay, this is what we're doing. Let's go. But sit down and just say, hey, I'm Dr. Stucki. And I've even asked you over the years, like, what exactly do you say? I ask people, what exactly do you say? How do you frame this? What are the words you use? And I've picked up a lot of those tips to start that conversation in a way that's direct and to the point. And then look at the pano. And, it's interesting. One of the previous podcasts where you guys talked about a lack of communication, it was a complication. They didn't say wisdom tooth. They said third molar, and the family didn't quite understand. And next thing you know, they did a surgery, taking out teeth that were already previously extracted, and it became a whole lawsuit, right? And that stuck with me. Using simple language, explaining things. I always point. This is the left side of your X-ray. This is the teeth on the left side in the back, the furthest one in the back, and then I try not to overemphasize every single risk possible, but the ones that are most pertinent to that patient based on clinical findings, and try to keep it short and brief. If patients have a lot of questions, then maybe going into little extra detail. But I think setting that tone of, if you use kind of catastrophic language and very scary things for patients who have very, very low risk, you might be setting yourself up for a patient who's very nervous about every single post-operative thing, when it's they're following the normal course.
Yeah. I like what you're saying. And as far as like potentially tailoring what you say to the individual patient, to the surgery they're having, certainly if we have like a wisdom tooth on a 30-year-old person, and we see that whenever number 1 and 16 are high, and the roots are halfway into the sinus, right? Probably we're gonna get a little more into the potential for sinus exposure, and potential for sinus repair surgery, all that type of stuff, where we wouldn't necessarily talk much about that for the routine 16-year-old who's just got regular wisdom teeth. But then also, I like to, so I'll give the spiel on the basic complications, whatever nerve injury, sinus exposure, healing, bleeding, all that stuff pretty quickly, but then asking what questions do you have, right? And giving them the opportunity to see, is this patient really concerned about something? Is there more they want to hit on? I mean, I find these days more of my patients don't really want to know stuff, don't want to talk much. It's more like, please don't, let's not get into all the complications. Let's just get the surgery over with. But there are some who really are concerned, and let's say they play the saxophone for a living, that's a person where we're going to spend more time, of course, talking about nerve injuries and what that would look like, and temporary paresthesia and how long it could last and all that type of stuff.
And you guys have talked about it before. That question you just said, instead of saying, do you have any questions? And you put them on the spot like that. No, your natural response is no. You say, what questions do you have? Which makes them kind of think for just a second. Wait, everything you just said. Well, I did have a question about this, and then you can clear up some of those, worries that they might have. And if they're not worried, they'll say nothing. Most people do, but if they're really worried, that's the time where it'll come out, and you can address some of those things. And I think that builds their trust even more, because and I've had people recently say, they ask that question after you say, what questions do you have? And you answer, you take the time to address their concern. They're like, you know what? You're a good doctor. And you're like, yeah, you're welcome. No problem. Just doing my part, taking care of you.
Yeah. So kind of changing it from a yes or no question to an open-ended, almost like a free response question that you're inviting, or the answer is more of a detailed sentence you're looking for, as opposed to, because changing it and making it a yes or no question is putting pressure on them to answer quickly, right? And just say no, yes. Like, so we want them, the pressure off, and we want them to say what their concerns are, and talk about it.
Exactly. And the last thing is, when you ask the question that way, you're almost implying that they do have a question, or that they might, what questions do you have? So then if they do have questions, they don't feel bad. At least me, when I go see my doctor, I feel like I'm inconveniencing them if I'm asking questions, right? It's like, just, let's make this go quickly. So if you give them that courtesy, then they feel a little more open to asking.
Yeah. Another one I think that's important in this realm of preoperative like discussions about complications and healing is kind of like framing recovery times. I've kind of gotten a lot more careful with what I say with this one over the years, because I think like the vast majority of surgeons, I've experienced this myself with my own surgeon doing back surgery, but the vast majority of surgeons tend to underestimate healing times, right? And they, like my back surgery surgeon said, oh yeah, within 2 weeks, you'll be back to work, you'll be feeling great. And And, when like 3 months rolled around and I still felt horrible, it was like, what's wrong with me? Right. Because clearly there must be something horribly wrong because I'm not following what
Right.
my surgeon told me. And I've had that happen where, I've had taken out a tooth. Usually it's an older patient, maybe it's a smoker, or maybe not even that, but people kind of extending and having pain, after maybe a month or getting into 6 weeks. And, sometimes if I had said it at the beginning, oh yeah, you're, 2 weeks from now, you're gonna be pain free, you're all good, no problems. And let's say they are having some achiness and soreness at the month mark, that's more concerning, right? If you set an expectation and now they're kind of like, oh gosh, what in the world's wrong with me? So I think
Mm.
I use more careful language and say, generally, I'll say a time thing, like generally at 2 weeks, you should be feeling close to back to normal. A lot of your pain should be gone. If you are having any pain, swelling, issues at all, let's get you back in, check you at that 2 or 3 week mark, see what's going on. It's not uncommon, to have like a slow healing process, but it's hard. Each patient's individual, that type of thing. I'm basically trying to say, here's the general course, but if you don't match this, that's okay, right? You might not be totally pain free in 2 weeks. Well, what are your thoughts on this one?
Yeah, I totally agree. It's so hard to know sometimes when we do surgeries and we send patients home, and most of them do fine, but we really don't know what their experience was like over the next week, right? Maybe a lot of them were in tons of pain for the first 4 days, and then they just managed it, and we never knew about it. So it's as surgeons, we just imagine everyone's fine unless they call us and come in with some big issue. So I think to your point, it is important that we realize that everyone heals a little bit differently, and we probably don't want to underestimate that, because then we're just setting them up to think that something's wrong. You know what I mean? I oftentimes, and this is something we did in residency, the first 2 or 3 days you're going to be really sore, swollen. That's totally normal. And then I'm going to be sending you with some pain medications, antibiotic Maltrins. These are the things that are going to help. This is how you're going to do it. This is going to help you get through that period, and then you'll slowly start feeling better. And like you said, by about 2 weeks, depending on what surgery it is, I think you're going to start feeling a lot better. And then just phrasing things in those ways, instead of oh, doc, when am I going to be back to normal? When can I go back to work? Oh, you'll be fine then, 2 days. And then it's like, depending on what kind of job they do or whatever other factors there are, it can set them up for feeling like you did something wrong, right?
Yeah. And there's been research on this. There's been, studies showing that there's a strong correlation between like effective physician-patient communication, and that improving the healing outcomes. So
Mhm.
a lot of studies showing that when you communicate and set up reasonable expectations, the way you communicate is supportive and not kind of alarmist, but
Mhm.
it's more in a calm, like we're gonna be okay fashion type thing. The patients just do better. So it's interesting to notice that.
And as a side note, because we just don't have time to talk about all these articles, but I think we have like 12. There was like 12 that I looked through and that you shared with me. Maybe we can link those in the show notes, just for people who are interested in looking at some of these different articles, because they go into a lot of different details and facets of surgery and speaking to people.
Yes. All right. So that's a little bit on like the preoperative stuff. How about language, intra-op, or maybe immediate post-op, where a patient is waking up from surgery, all that type of stuff. I think equally important to just be careful with the things we say things that are going to help this patient um, feel good. I mean, I pretty much, when the patient's waking up, I almost always say, hey, everything went great. Surgery, went well. I'm using very positive descriptors. I want to, even though, especially with someone waking up and they got Versed on board and you think, oh, they're not going to remember any of this, but planting that seed constantly. And I have my team doing this as they're wheeling them out in the wheelchair, telling their
Mhm.
ride, their escort, hey, everything was awesome, went great. You want them, having um, that kind of positive feeling with them about the surgery. Now, if some it did happen and there was an issue, you had to leave a root tip, there's a sinus exposure, yes, we're gonna talk about it and say this happened. But we're always following that up with, you're gonna heal great. You're trying to see this positive thing that really does make a difference. And surprisingly, there's articles that show that as well, that if you're using positive language in the immediate post-op period, people actually do physically heal better. It's a really interesting phenomenon. Any thoughts on that one?
Yeah, I read one of those articles and it had like exact phrases, like if you say these exact words, like absolutely, it was wonderful. Like there was a whole list of like just very clear, concise, positive words. People associate that with just a better feeling overall with the conversation versus other words they said, like for example, much. I don't know what it is about the word much, but people just left feeling like something was wrong. Like, oh yeah, it was much, better than we thought, or much this, or like I think you're gonna have a much easier time. Whatever it is, it might be subtle, but they like polled all these people and just found that simple ways that we communicate the same message might make them feel different about the experience. Now, specifically about the surgery, so there are two things I want to talk about, and honestly, maybe even more, because I think this is an important part. So one, we got a lot of patients who are asleep, right? So I think we have a responsibility there, right? So you've heard there's stories out there. I actually got just yesterday a random friend who's not even in medicine sent me the article of that anesthesiologist who, I don't know if you heard about this, but she got fired because of a patient. He was trying to record the pre-op or post-op discussion, forgot about it. His phone was on record, and they ended up putting him to sleep. It recorded the procedure, and after it was over, he listened to it, and it was vulgar, horrible stuff about him and about the other patients. So, that's the part of it is even when patients are asleep, I think it's our responsibility as doctors to be professional, to watch what we say. Because even if the patient's not hearing or recording, I think it's just common courtesy. And on top of that, their family could hear, other people in the room next door might be able to hear. So it's important how we communicate there. And then for the patients who are awake, that's a whole different scenario. Because, in the operating room, the communication, as we all know, is all across the board, right? But we have a unique experience when we have these patients who are awake and they're experiencing this, and they can't see what we're doing, right? All they can do is feel and hear. And so when they hear things like, for example, one of the articles specifically said, "Oops," or if a assistant winces, or if they say, "Ooh," small things like that, they hear that and they think instantly something just happened that wasn't supposed to happen, right? And so I think that it's important that as we do things, even something as simple as a tooth breaking, talking, there's two approaches. One, you could talk the patient through it, kind of, warn them, hey, you might hear some noise here, a little bit of pressure, a little bit of that. That's one approach that the articles talked about. And another approach is simply just basically distracting the patient, right? Music or, maybe a movie or some other kind of thing on there, and just acting like the surgery's in another world. But those words that we use, if you're saying, pass me the 15 blade, oh, give me the scalpel, give me the cow horn, I want the really big elevator. No, not that one, the bigger one, the longer one, the sharper one, like we do that, or assistants will do that if we don't tell them. They'll be like, oh, do you want the upper or the really sharp upper that we use sometimes for the hard teeth? And you're like, okay. You're like, I want the regular easy one, and you point to the big scary one, right? But it's like those words that we use, the patients, they have no context for it. All they hear are these, big, long, sharp, cow horn. These words that just sound kind of freaky, especially if they're nervous. It can make their experience totally different than if your team is on the same level and you have a way of communicating that's just very calm. Maybe something breaks or something happens, and you just say, can you hand me the next instrument? And they know that, if you're using the small elevator, the next one is the big elevator, and those kind of things make it seem very normal for the patients. And that's something that Dr. Greg, I actually learned from his emails. He talked a lot about, he found that when he started communicating that way in front of his patients, they were a lot less likely to be scared about what he said.
Yes. Yeah, I love this point that you're bringing up, because especially during these cases that are local anesthesia, the patient's aware of what's going on. I think we need to be very careful about every little thing we say, the way we act, because patients are picking up on everything. They're, worried about everything. And so exactly like you're saying, you need to be using like neutral terms that will not scare the patient and think like something abnormal is happening, that there's, some big problems going on. One thing is I've noticed, is especially when we're doing like the local shot, for some reason I would say, I think it was from our dad, who's a general dentist, but
Yeah.
it was okay. There's gonna be a couple pinches here, and we use these descriptors to try to describe what pain's about to happen.
Mhm.
I stopped doing that because I got enough patients that once I said, okay, here's a couple pinches, and I gave him a shot. It's usually like an older man, usually, who will like be like, well, that's more than a pinch. Why did you call it a pinch? Like, I'm really upset you called it a pinch because that was like a stabbing, like horrible pain.
Yeah.
And I'm just like, so now I just don't even describe the pain. I just say, okay, there's going to be a couple injections, um, or you could say a couple shots. But I'm trying to not be descriptive. I feel like when you say, hey, this one, the palatal shot, right? Hey, this is going to be a real zinger, take a breath because this one's coming in hot and it's going to hurt like heck. I feel like when you say that, it almost heightens their sense of sensitivity. They become more hyperactive, more anxious. So, I mean, there's no way around it. The palatal shot is going to hurt like heck, right? But
Right.
if you describe, oh, this is going to be a horrible shot that's about to come, it almost puts another layer of pain on the shot. I don't know if you've experienced.
Right. Right. Well, you can always this is going to be a red hot searing fireball. And they're like, well,
Yeah.
it wasn't that bad. No, I know what you mean. If you say something and they're like tense and they're stressed, and I have experienced the opposite when I was in residency, where maybe I didn't say enough to prepare the patient, and then the shot hurt more than they expected because I didn't, say anything, and then they're like, "You didn't warn me. I wasn't prepared. My mental, state." And so it's like
Yeah.
it's tough. I mean, no one likes the shots, so it is hard to know what to say there. I feel like getting down just something to say that's nice, and just it is what it is. So that I used to find myself being, oh, I'm really sorry, sorry about that, sorry. Now I don't really say that anymore because it's like it's everyone knows it's coming. It is what it is. We know it's unpleasant, but I think the way we speak about those shots does make a big difference. To be honest, though, I don't know if I have the answer there for that one.
Yeah, I'm not sure I got it right either. But I think the take home message is like, maybe be aware of the things you're saying. Think about how a patient is perceiving that, right? So if you say, let's say you're taking out a tooth, you got a forceps on it, the crown breaks off, there's a big snap, what is your reaction? What is your assistant's reaction? And what does the patient interpret from your reaction there? Is your reaction, oh, shoot, or hey, or the assistant, oh my gosh, do you want me to grab the handpiece? Like,
Right.
yeah.
Or if you're looking for an instrument and your assistant shouts down the hall. That's one of my pet peeves is it's hey, can I get the number 23, right? Instead of saying whatever it is, cow horn, you just can I get the 23? Hey, Eliza, 20, wait, I didn't grab the 23. I need hey, what no, I didn't have the right force. And everyone starts going nuts. It's like, guys, it's okay, that kind of stuff happens. Let's just go grab it. And I think if you have that conversation with your staff, I there's this element of everyone wants to be prepared. We got to be efficient. It's obviously surgery. The surgeon expects things to be running smoothly as well. But as a surgeon, if we let them know, look, if let's set everything up, let's be prepared. But if we're missing something, let's just go. Let's go get it. We don't need to make a big frantic commotion because I just always think, what is the patient thinking? Like, they must be going to get like the reinforcements. They're running around and grabbing some other. I've had people come in. The classic story is, he was struggling for half an hour and then he had to go. He was sweating. He said, "I'm really sorry." He had to go step out and go get some extras equipment. Some the big guns. Then he came back in and was able to get it out. And it's like he's probably just looking for like an Ash forcep or something. But the way you react in those very simple situations too, I feel like kind of sets the tone of being professional and prepared.
Yep. 100%. All right. So the next point is kind of post-operative period and what we talk about to the patient. So just a quick story to introduce this one. We're all in different settings. In my current setting, oftentimes, and I think for a lot of our surgeons, even those that are maybe in their own private office that only have one office they go to. But oftentimes our patients will follow up with their like primary general dentist provider, and so there's potential there for some issues as far as language goes, because we'll have I actually gave a lecture about this to some of the dentists that are in the group that refer to us. But one story, which is a common one, is we do a bone graft after an extraction. Let's say it's tooth number 30. Patient, has some inflammation, the usual kind of spike in inflammation that fifth, sixth day. Generally, I try to see them myself, but occasionally they'll see the general dentist. And recently we had kind of a newer grad dentist see the patient at that 1 week post-op, and like that top layer of bone had kind of sloughed off, and the membrane as well. And this new kind of dentist looked in there, and oh my gosh, they said, it looks like, gosh, I can't. It's a big hole, and it looks like all the bone graft fell out, and wow, I think that probably the surgeon might have to redo the bone graft, and this is really concerning. And kind of was using that language, and the patient got really, really worked up and was like very anxious right after leaving the dentist, basically because the dentist kept saying, I don't think this is right. I think everything fell apart. I think you need to have the surgery done again. And so, so then they said, okay, go see Dr. Stucki. So they see me like the next day, and I take a look. I mean, there's no infection, there's no swelling. It actually looks pretty darn good. Gingiva is nice and pink and healthy. Looks like that top layer of bone has sloughed off, but we even take an x-ray and show that most of the bone is still there. It all looks very normal, right? And so that's what I say to the patient. Hey, this looks very normal, very common for that, to kind of feel a little bit like a divot there because the top layer kind of sloughs off. And the important thing is it's not infected, there's no pus. Here's some of the oral hygiene instructions, and now we just stay the course, you're going to be fine. And so the patient's calming down, but it's a difficult situation because now the patient, oftentimes they go a couple nights before they see the surgeon, and they can't sleep, they're anxious, they're sure that the whole thing is just falling apart. And then when they see us, we calm them down, right? I'm sure we've all been through the experience of, it looks fine, don't worry. But it's almost kind of like sometimes the damage has been done, and now now they're kind of between. Now they're thinking, wait a second, my general dentist acted like the world was falling apart, my surgeon says it's all fine. And so they're going to lose confidence in one of those providers, right? Like, and generally, unfortunately, it's the dentist, because the surgeon, he's the one who does this all the time, and we say it's fine. And my dentist, like, why were they freaking me out? And I just lost like 2 nights of sleep. And so I was trying to coach our general dentist to say, be careful with what you say, because using alarmist type language to a patient can be very harmful. It can delay their healing. It can cause them to lose confidence in you. It causes them confidence in me. And, it's oftentimes what you're seeing there is pretty normal stuff. So, what are your thoughts on this one?
Yeah, couldn't agree more. I mean, I had an identical situation a couple of weeks ago where, you go into a room like that and your assistants have prepped you saying, hey, this patient's super angry, really upset, just get ready. You know what I mean? And you're like, what is going on? Go in there, you try your very best to be understanding, take a look, everything's totally normal. And so I think you have to be a little careful, I guess, as the surgeon, because you tell the patient things are normal. You like to explain to them. I like to explain and, kind of talk them through why I think it's that way and not just like dismiss them. This is normal. Don't stop worrying about this. Can I explain what my rationale is, what's going on? But then inevitably they'll say, well, what was the dentist thinking? Or why did they say that to me? And, the truth is, I don't know why they said that, but I always like to give people the benefit of the doubt. Other providers, I don't know what it looked like that day when they saw you. Probably do know that it was probably pretty normal, but you say, I don't know what it looked like that day, and I'm not sure what they saw, but I'm glad you came to see me. I did the surgery. I've seen a lot of these kind of things, and based on how I see it today, I think you're doing really well, right? And try not to erode that confidence they have in other providers too, because I feel like it kind of just goes around, right? Like if you then say that the dentist was bad, then they go back to the dentist and they tell them that, and it's like a back and forth, and they're just kind of like you said, erodes that trust. So I think it's important, like you said, to have good communication. A couple of these articles talked about how just the team communication, they ranked just between the providers, between the surgeons and their assistants and the other surgeons. If that communication level was ranked higher, the patients had better outcomes and the patients felt better. Not even what they said to the patients. Completely separate. If the teams communicated better, they found that the patients had better outcomes. So I think that that's an important thing, because I've had a couple times where, and we've even talked about this, me and you, where I questioned, should I call this other dentist? Should I talk to them about something? Should I call this patient? And, sometimes I haven't, because it's like, I don't want to bother them, or, who knows what they're going to think, or, it's probably going to be fine. And in retrospect, it's like, no, I should have talked to them, right? I should have given them the courtesy. I should have called them. Should I explain these things? Talk to the patient, because you can avoid a lot of issues by just communicating with other people about what happened, about concerns, about complications, about things like that, rather than just waiting for those issues to happen.
Yes, totally. Yeah, good point on not throwing your dentist or whoever was that saw your patient, even if it's another surgeon, don't throw them under the bus. Use positive language about that person, or neutral, like you're saying, I'm not sure what they saw. All I can tell you is what I'm seeing now. That type of thing is very important.
Yeah.
I think so. That was grafting. I think the other really common potential for that to happen is with nerve injury. Oftentimes
Mm. Mm-hmm.
and I try to tell all of my patients, thirds and whatnot beforehand. Very common to have temporary numbness in your lip and chin for a few days, sometimes up to a few weeks afterward. But the new dentist who hasn't seen that, oftentimes, if the patient ends up in the chair, let's say the 1 week mark, and I'm numb. I've had new dentists that are kind of inexperienced say, oh my gosh, you're numb. It's been a week. Wow, that's not good. You might need nerve surgery, and they really freak the patient out, and so the same thing kind of happens where we gotta get them back in the office. We calm them down. So I'm always trying to talk with my dentist and like say, hey, here's what we should be saying. Here's kind of even some scripting you could use. Letting them know, hey, it's very common, to have numbness during those first few weeks. Very uncommon to have, permanent numbness. If you see a patient who's numb within those first couple of weeks, act positive, use positive language, get them to me as soon as you can. But try not to be alarmist and use negative language, because that can actually cause physical delay in their healing. So just another common thing is with that paresthesia.
Mm-hmm, for sure. And going along with that, I saw some of the articles. I guess there's not a lot of research specifically about what surgeons communicate with, but most of it's like primary care providers and other type of like internal medicine. But one thing I read about was as surgeons, we tend to be pretty good about just describing the surgery, like technique or complications, or what do we have to do if this goes wrong? What kind of surgery is it? It's very like, you have this issue, this is what I would do, and we can explain that, right? But where we as a specialty, or I guess as a group of people, kind of tend to miss the mark from what they say is maybe being a little more empathetic, right? Listening to people, that sounds
Yeah.
like, it sounds like this really stressed you out over the weekend, right? And then having a little sympathy. That's tough. It's it's no fun to feel stressed. And again, I'm glad you came to see me. I'm glad we can have this conversation. Let me, share what I see. And then if part of that is due to something that we did wrong, complication that we really did, the question is it okay to say sorry? Like, is it okay? Is that admitting guilt? It's like that whole, and from what I read, there's a couple articles on it, is have sympathy for negative situations patients go through that aren't necessarily acts of, anything we did wrong, right? It, like, let's say we didn't leave a root tip, everything went smooth, and they're still having pain in that area. It's fine to be sympathetic. That's not saying you're guilty. We don't need to think that way. If we do have a complication, it's okay. I apologize. That's how that situation turned out. You know what I mean? And these are the things we're gonna do to make this better. For patients who are really anxious and worked up, I think it does go a long way just having them feel like they're heard. Because they say the vast majority of the reason cases become lawsuits, or people have these relationships that go sour is because they don't feel heard and they don't feel like they're being communicated with. You know what I mean?
Yeah, exactly. Yeah, so important not to take a defensive stance. Like when, let's say, you see a patient at the 1 week mark, they tell you how the horrible pain, probably have dry socket, they haven't slept, missed work. We've all heard this. I mean, the tendency sometimes is to be defensive and say, "Well, I did nothing
Mm-hmm.
wrong. I mean, this is normal." Like blah blah, and like don't throw this on me. I've stopped saying any of that, and I usually my response to all that is, gosh, that sounds horrible. I'm sorry you're going through this. That sounds miserable. Tooth pain is the worst, man. I've had that as well, and gosh, it's not fun. And, I'm sorry you're experiencing this pain. This is a fairly common thing. And nothing wrong happened in the surgery. This sometimes this just happens. We're gonna help you get through this, but I mean, I feel bad that you're going through this pain, right? I don't think there's anything
Mm-hmm.
wrong with that. And I think, yeah, like you're saying, sometimes we get so focused on I can't admit faults because the patient will latch onto that and they'll think that I did something
Right.
wrong in the surgery. That's not my experience. When you apologize for a patient and their suffering, I've always had good outcomes, and people, they want to talk about their pain. They want you to understand and know that it was hard. So I think anything you can do, like you're saying, to be empathetic, sit sometimes with them in the pain and understand it, and then try to help them, to focus on the fact that it will heal and it will be okay. It just may be a little while longer, that type of a thing.
And it gets even a level harder when the patient actually outright does try to blame you. If they
Yeah,
say, "Oh well, you said this or that," or during the procedure, this happened, and this XYZ, or they try to make it seem like it was specifically your fault. Right? It's really hard not to get defensive. No, that's not what happened. Don't say. I've heard doctors say, don't say those things about me. That's not fair. That's not what happened. Like you
yeah,
didn't see. I was doing the surgery. I saw what happened. That's not what happened. Don't start twisting the story. If we start making it a battle like that, it's just not going to go well. And I'm sure all of us experienced during residency, like there could be a lot of stuff that happens in residency with communication. There's so many different surgeons and residents, people and experiences, and so many times I had a patient I would go see. I never even met them before, and they just unleash, a fire hydrant of blame against, me, right? Your residents, and they'll just come after you, and the vast majority of the time, if you just listen to what they have to say and be sympathetic, and then try to direct it to, okay, where do we go from here? Let's do this together. Like I'm listening to you. I'm also experiencing these things, and this is what I think we should do, and then involve them in that. It just tends, it seems to me, to go a lot better than trying to get defensive, because then at that point it's like you lost trust, and you probably don't want to talk to them, and they don't want to talk to you, and it's like the likelihood of you being able to be very effective in helping them get through that complication is pretty low. And so it's like they're probably just going to go see someone else who's going to say something bad about you. And it's like just a lose lose.
yeah, yeah. Really good point. To not jump into the fray, and when the patient maybe is in the attacking standpoint, to not attack back, because no one,
Mhm.
yeah, no one, gets better for that. But to listen and say, I hear you. Here's what sometimes the mirroring. Here's what I hear you saying. Is that right? Okay. Here's from my standpoint. Here's what happened, and here's how we can fix it. But yeah, certainly I've never had um, good reactions when you tell patients to just stop talking, just stop saying certain things. It's like
Yeah.
that only gets them more riled up.
Yeah. I've definitely seen that. I am the surgeon. I have the experience. You listen to me. Like, hey, I've seen that work, but like, I definitely don't think that's not the approach I want to take. And
Yeah,
I've had a lot of success, being understanding to people.
yeah, for sure. Well, and then one other kind of aspect of language is, I think we've talked about this. It's been a couple of years on the podcast, but there's something called the second victim effect, where maybe we do have a complication or a problem that happened, and patient is suffering. Is one is the internal language we use with ourselves. Sometimes we can be pretty hard on ourselves, and beat ourselves up, which kind of decreases your confidence further. Honestly, I've seen this happen with other surgeons where like a wrong tooth was extracted, and then they got so down on themselves that literally the next day the same mistake happened again, and almost
Man.
like when you become very negative internally, it almost opens you up to more future problems. So all that to say is very careful, just as careful we are with the language we use with our patients, we need to be careful with the language we use with ourselves. And then the next step is with our team and our assistants and our front desk, it's being careful with that. Any thoughts on that one?
Yeah, no, I've definitely, couldn't agree more that when you take an experience and you beat yourself up over it rather than trying your best to learn, internalize, learn, what lessons can you take away from that and then move on and become a better surgeon. If you it's the same concept for all life. If you take those negative experiences and let them get you down more, decrease your confidence, decrease the way you treat your patients going forward because you're nervous about that thing. It's not something that's going to help you become a better surgeon. So I think thinking about that, and it's also important, I think, to just talk these things through with other surgeons who you trust, right? I recently had a friend call me with almost identical situation to what you just said, and just say, hey, this is what happened. This is what I did. This is how I feel. What do you think? And so most of the time when we have those conversations with each other, I feel like it helps us to kind of like think it through, to realize we're not alone. Lots of people have done these kind of things. How can we avoid these issues going forward? How to respond? I've done that with you all through dental school and residency, and it's very helpful to have someone like that. So I just encourage people, if they have those experiences, to talk to other surgeons who have been through that, and just use it as a learning point. Because it's like my my program director and chairman, Dr. Bauer, would say. He said, I'll probably butcher the quote, but it was, through experience. No, shoot, I already butchered it. I told you. It was, failure brings experience, and experience brings success. Something to that effect. And he said, I have a lot of experience, and so it's, you know, all great surgeons have had a lot of complications, have had a lot of failure, but they got through that, right?
Yeah, exactly. Yeah. I think in the realm of communication, like we've been talking about so much, it has to deal with the expectation, you help the patient set. There's a table that they showed us in residency where it's like the patient's expectation, um, like a surgeon outcome is less than desirable. Patient outcome, their expectation was met, or and then it's like another quadrant of the I wish I'll send a link in the show notes. And there's like another quadrant that's like patient or surgeon outcome is higher than expected. Like basically the surgeon thought it went great, but the patient's expectation it ended up lower than they thought it would be, and the outcome is poor. All that to say that like the most important thing is the expectation that you help the patient set and meeting that expectation. So all of that to say that especially pre-op and even post, we're always trying to mitigate the expectation and let them understand what is realistic, what's normal, all that type of stuff.
Mm-hmm. For sure. By the way, I just found this quote because I knew I totally messed it up. Whatever I said earlier, it was probably totally wrong. So with success comes confidence.
Yeah.
But with failure comes experience.
Okay.
A lot of times we can be like, so we feel so confident, we're like on top of the world because everything's going right. But when we fail, we're like, we instantly think that everything's we're toast. We're never gonna come back from this. But the truth is, that's what gives us the experience, right?
And that's when the learning happens. Really, is we
Mhm.
all learn more during our failures than our successes. I mean, after you have a great surgery and it's totally successful, you don't think twice about it. right?
Right.
It's the failure, the complication. You think about, you brainstorm. How could we have changed that? You research, different ways to do it next time. That's where you learn some stuff. So there's always a silver lining to every, complication and issue that happens.
Right.
So just the practical takeaways I think that we've kind of run through here in this episode. One, before surgery, it's of course important to be transparent, but be positive and don't use alarmist type tones or language. To set realistic expectations, timelines, personalize the information to that patient. How about what would you summarize the intra-op / anesthesia language to be?
I would summarize it as be professional during the surgery. Use neutral language, reassuring language with towards the patient and with your team to prevent to help the patient have a good experience during the surgery itself, as good as they can.
Yeah, and always assume the patient can hear, maybe even if they are sedated.
Mm-hmm.
But especially locals, always be professional with your language and positive, and even when they're asleep, type of thing. Post surgery, what are your take home points for post op?
Set expectations, reasonably. Leave the window open for the variability that different people can have with healing. Let them know you'll be there for them and be there. And then when complications or miscommunications arise, be understanding with patients, be upfront with any complications, and communicate with them in such a way that you can be on the same team and work towards the goal of recovery rather than being adversarial.
Yeah, 100%. Making sure you're on the same page with the language you use between yourself and any other providers that might be seeing your patients. Yeah, and continuing to use that positive reinforcing language. Be empathetic, like you pointed out. And then there's the kind of internal / language we use with ourselves. I think be compassionate with self-talk, seek peer support when complications occur, be patient, look for the positive things that can come from difficult complications. All that is super critical. All right, so we'll put links to some of these articles that talked about this topic. I know this is kind of maybe you're thinking listeners consider this more of a soft topic versus a hard, cut and dried, like here's how you take out a tooth type of thing. But I honestly have noticed so much power in language and the ability to help patients heal, that it's just another, I see it as another tool to honestly to help a patient heal. So why not get good at that, right? And use that tool. It's can be just as effective as a scalpel or a suture to help someone heal.
Yeah, absolutely. Well, thanks for thinking of this topic. And like you said, it's something that as surgeons, not the first thing we think of, but it makes a huge difference on our patients and their experience that they have with us and with the surgery itself. So thanks for bringing this up. And we should share some of these articles with everybody, because there really is actually, I was pretty impressed and intrigued by all the different research that people have started doing on communication in surgery.
Yes, kudos to those people who took time to make these great research articles. All right, Jake, thank you so much for your time. I appreciate you.
Yeah, thanks, Grant.
Yeah, bye. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.